Hello, this podcast is about the diagnostic challenge of Lentigo maligna. It is a challenge for the clinician because it's on sun-damaged skin of elderly people with multiple types of pigmented lesions. So the flat, early SEPK, actinic keratosis, solar antigen, just pigment incontinence with this grayish color on dermoscopy, and of course junctional navy. It's also a challenge for pathologists because it's ambiguous at early stage. We have melanocytic hyperplasia in sun-damaged skin and contiguous lesions render sampling hazardous. It is a therapeutic challenge, and we know that recurrence after conventional surgery is very high. It's anyway sometimes very cosmetically difficult, and we have often amelanotic involvement at the periphery. Nobody knows what appropriate margin are, 5 or 1 centimeter. In this large study, it seems to be in between 6 and 9 millimeter. The study was in situ melanoma, not only lentigo maligna, but more surgery or stage excision is what is recommended because of this problem. It's also a time challenge with this concept that solar antigen could evolve to lentigo maligna or unsteady lentigo. It's a field of cancerization, and people suppose that the recurrence may come from the margin. It's also an ethic dilemma with elderly patients, with really should we bother them with treatment, in particular when it's disfigurating and people have comorbidity. So, how to diagnose lentigo maligna? This study is quite old now, but it's really one of the best sensitivity and specificity feature, the asymmetric pigmented follicular opening. So the concept is that there are some mutation in the stem cells of the hair follicle, and then they migrating upwards, colonizing the skin and creating rhomboidal structure around the hair follicle, and then the nodule with the lentigo maligna becoming invasive, so lentigo maligna melanoma. So just in slide, you can see here the cells migrating upward and developing in nests with the correlation of the asymmetric follicular opening here on dermoscopy. Pralong et al. Have described some new criteria with darkening at dermoscopy examination, target-like pattern, increased density of vascular network, and red rhomboidal structure. I just show this beautiful illustration published in the JAD in 2015. It does recapitulate a lot of the different features that have been described. As we said, the gray color and asymmetrical pigmentation, the annular granular pattern here, the circle within the circle, the pigmented rhomboidal structure or ribbon, some people say it. Here the target-like pattern with a dot inside the hair follicle. Here the increased density of vascular network that can be very tricky in elderly skin, sun damage, but anyway, and the obliterated hair follicle that is a worrying feature for something that could become invasive, and the white gray scar-like area that are also quite characteristic. A good clinical and dermoscopic characteristic of lentigo maligna on non-facial skin is this angulated line or polygons that have been described and quite characteristic. Something that I want to say is when you're quite good at dermoscopy and found these little dot things, you can find very early stage lentigo maligna, and this patient was only 35. I think we're seeing more and more of this early stage lentigo maligna, at least in Australia where I'm working. One question also that you should always think about when you have AV sun damage is to look at all this pigmentation, but also have a little bit of a palpation and try to find this amelanotic or thick area that could be desmoplastic melanoma, and think about that. a good way when you're not sure about dermoscopy is to do some long-term monitoring. So 75% of the lentigo maligna change in 3 months. So we advise to do a 6 months monitoring, and it's an excellent way to make sure that the freckle is changing and need to be biopsy. Of course, the best way to do a diagnosis is reflectance confocal microscopy. This microscope allows horizontal section of the skin with a quasi-histological resolution, 1 micron lateral resolution, and the visualization of the epidermis and upper dermis happen to nearly 0.2 millimeters. So perfect to see a lentigo maligna. There is 2 machines that are commercialized, and this one you need to press an adhesive ring, and then you have a very good micro correlation. With the new 3000, and this is an ancient model of the 3000, you can move freely the microscope, which is even better. So horizontal section, you have here an equivalent of confocal and pathology. You see first the stratum corneum that is very bright, then the granular layer with the keratinocyte creating a honeycomb pattern, then the spinous layer with smaller keratinocyte, and at the junction you will cut the papillae and see the pigmented cells because melanin backscattered all the light and appear very bright. Now on the face, often we don't have papillae, but you can still see these cells. So the confocal pathology correlation have been very well described. We have multiple atlas and articles that describe that. It's especially good for difficult lesions like lentigo maligna and amelanotic melanoma. We have published a long time ago a big series of lentigo maligna and benign macule of the face with the help of multiple continent dermatologists. One of the very good criteria is Pageto itself. They're round and very large. When they are dendritic, it's a little bit more tricky, but we'll talk about that later on. And the fact that you can't see the ages papillae that you see normally because they're destroyed by atypical cells. The asymmetric follicular localization of atypical cells is also very beautiful, directly correlating with your dermoscopy feature here. Broadened and honeycomb pattern is a negative feature. It's normally seen in benign macule actinic keratosis and seborrheic keratosis, so it's a good criteria to say it's not lentigo maligna. We found also in this big series that we had often large nucleated cells within the dermal papillae. So this is bizarre because we know lentigo maligna, it's not invasive, but I think it's just because the papillae are hardly recognizable, and so we were not totally sure where we were. It looks like we are in the dermis, but we're not. So when you have 2 of these major features, a score of +2, 4 of the 3 positive one here, a score of +1, and 1 negative things, and you just had all of these. If you obtain a score of more equal to 2, you have a specificity of 76% and a sensitivity of 85% for the diagnosis of lentigo maligna, with a good inter-agreement of a good agreement in between observers. Sorry. So an example of ill-defined macule with no clear-cut feature of lentigo maligna, you just put the microscope on the skin and you see already in the epidermis these very large cells. When you go to the junction with this hair follicle opening there, you can see the cells that are corresponding to these very large cells at the junction. We have some differential diagnosis, of course. That's an example of a very large macule with no much feature for lentigo maligna. You can monitor, of course, but it's difficult to know where to biopsy. And when you go on this, you can see some pigmented cells, some a little bit bigger there, but that's typical of sun damage, and you can be quite confident. It's just a solar lentigo there. Here, another example of a pigmented macule with rapidly changing pigmentation. You can see on dermoscopy all these gray dots. As Professor Giovanni Pellicani said, when it's gray, don't spray. You need to make sure. But the gray dots like that are quite characteristic of melanophages, and they're very easily seen on confocal with this photo extract from the atlas. showing some cluster of this very interesting shape, but smaller cells with no nucleus most of the time. So we can diagnose this on confocal pigment incontinence quite easily. Where we struggle is when we have a lot of dendritic cells, and sometimes you would say this is a typical Lentigo maligna, and you will be surprised to find an actinic keratosis with some sort of Lentigo. On CD1A immunostaining, you find all these dendrites, and they in fact corresponding to Langerhans cells. So confocal is not perfect, but it's a good machine to do that. Now this podcast is already too long, so I will treat about mapping and Lentigo maligna margin in a second podcast. Thank you very much.